Okay, Dr. Green, it's all yours. We're working it. There we go. And you need to unmute yourself, Dr. Green.
There you go.
Okay.
Yeah, I said I can't make any promises about how seamless this will be, but all right. Well, thank you very much for having me. I've been a member of NAMI kind of off in the shadows since I was really out of residency. I lived in Concord for a long time, Concord, North Carolina, right outside of Charlotte, and there was a NAMI Charlotte, but there were very limited NAMI kind of tendrils out towards Concord, and I'm sure that's probably changed by now. But I've always really believed in what NAMI did, and really excited that you guys invited me. I want to shout out to my friends, Margaret and Rebecca, and say that it's really cool to see you guys there. And we're so glad, just really glad to be here and sharing my kind of my views on this disorder. Kind of is it a disorder? Is it not? And we'll talk about that a little bit too. I am going to talk about autism spectrum disorder today and co-occurring mental illness. And what's interesting is this could have been like super, super long. And so if it feels like when I'm talking about this, I'm doing a 50,000 foot view, I really am. I just kind of wanted to give you guys a taste of what's out there. There are so many resources for learning about autism. Sadly, not as many resources for helping adults with autism as I would like. That's a real limitation that we have as a whole in our just in the mental health system in general. Sort of like once you turn 18, you magically don't need anything anymore. And we all know, I'm sure you all know that, and I certainly do, treat adults only. And so everyone I see is in need of those kind of things. And it's that's something that if we can pull our advocacy muscles together, I think that needs to happen more than anything. So this is going to be a nice 50,000 foot view, and then I'm going to just like open it up and let's chat about it and get your questions and kind of go from there. So pretty informal. I'm very chatty. I'm very animated. Usually I emote a lot, so I'm going to talk with my hands some. And but I definitely welcome any interruptions. I have 3 children, and I get interrupted all the time, so I'm used to it. And feel free to jump in if you need to or want to add anything, or if you have a question.
Karen, I'm going to be the first to do that.
Cool.
This is Glenn. I've got the screen wonderful right now. I've got your presentation on the left and just your picture on the right. And what I did was I clicked on your picture when it was in that bar of 6 people. I clicked on that, and then I went up and did view side by side. So I don't know if that will work for anybody else, but it's working great for me.
Awesome.
Okay.
All right. I just know that my screen looks totally different from what y'all are seeing right now, so I can't advise. Yeah. So okay. Good luck. Good luck. So my first disclaimer, all of these opinions, any opinions that I'm giving are mine. I'm not speaking for Wake Forest or Atrium Health Wake Forest, or as Louise pointed out, I will always be Baptist to me. It was Baptist when I graduated from here, and I just won't ever change that. So, but these are my views, and I want you to know that you know, those of you who have intersected with mental health, as you have in many different fashions, whether it's as a patient or as a peer or as a family member, you know that if you talk to 10 different psychiatrists, you'll probably get 11 different answers. So be aware that perspective is everything, and a lot of it has to do with kind of just my personal experience. But given that we're all, you know, imperfect beings, that's kind of the best we have to go on most of the time. So just be aware that this is kind of my perspective on things. And I don't have any commercial affiliations, never spoke for a drug company. They didn't care what I thought. So, which is just fine with me. So when we first, when Louise kind of reached out to me and she talked about dual diagnosis, right? Like having a diagnosis of something else along with autism, or autism spectrum disorder, as it's now called. I wanted to kind of address that terminology. And the reason I do this is because it might be confusing for some people. So I just want to kind of clarify. So what does it mean to be dually diagnosed? Well, traditionally in psychiatry, we use that to refer to substance use disorders and other psychiatric conditions together. So when we say dual diagnosis, that's usually what we mean. So we could consider having more than one diagnosis of any kind as a dual diagnosis, but that might confuse people that you're talking to about it. So I like to kind of use like co-occurring or coexisting diagnoses, because using dual diagnosis kind of rings substance use bells for a lot of people, and that just saves a little confusion. But that's by no means like an official thing. But I think if you were talking to a healthcare professional, that's probably what the bells would go off for. So I'm not going to give you what I would give our residents, which is like the whole 9 yards of what our DSM, you're familiar with that, I'm sure, the Diagnostic and Statistical Manual that has all the menus of everything that could ever be wrong with anyone, right? And the thing about the DSM is that it tries to pigeonhole people and it tries to put them in little boxes, which the longer I do this and the longer I'm just a human being, I realize that that's impossible. So the DSM has its faults. It has its what I think are frank inaccuracies. But as my daughter would say, I didn't pick up the phone if they called me to ask my opinion. So my opinion is that we have to rely on the DSM because that's how we talk to each other as professionals or as medical members of a medical or psychological team. But it's only because we have to, not because there's some corner on the truth. So I'm not going to go through all the criteria because I think that gets sort of distracting and in the weeds. So I'm just going to talk about it at a little bit higher level. So the first person diagnosed with autism, interestingly enough, recently just died in 2023. His name was Donald Triplett, and he was diagnosed in 1943 by Dr. Leo Kanner. And Dr. Kanner, along with Dr. Bleuler, who studied schizophrenia back in the early days, they were the ones who kind of coined this word, autism. There's a very interesting history as to how autism came to be a diagnosis. And I would encourage you all, if you can keep from going down the rabbit hole too much, Wikipedia has a really great autism spectrum disorder page, and it's very in-depth. Whoever did it did a remarkable job. But there's a nice history of kind of how it came to be, how that diagnosis kind of evolved. Suffice it to say that it is now considered a neurodevelopmental disorder marked by restricted and repetitive patterns of behavior and deficits in reciprocal social communication. So when we diagnose somebody according to the DSM, and there's little menus, right? There's like, you have to have 3 of this and some of this and some of that and a sprinkle of this, right? So it's about the person has to have some difficulty in an area of communication. So in speaking with or communicating non-verbally, there's difficulty in that, as well as either repetitive behaviors or rigid focused interests, or rigid kind of routines of behavior that are hard to kind of break for them. DSM-5, which is our most recent manual, has shifted, and you all probably became aware of this if any of you have family members with either an autism or what was formerly known as Asperger's syndrome. It all got lumped under a giant umbrella called autism spectrum disorder. And a lot of that's been a matter of hot debate over whether or not that was a good thing. And I think the jury is still out on whether or not that improved access to services or restricted it. Probably depends on where you fall on that spectrum, honestly, whether it helped you or hurt you. But diagnoses like pervasive developmental disorder and a couple of other things along with Asperger's syndrome were all kind of lumped under ASD, which is how I'll refer to that. Now, I liked this quote, which also came from the Wikipedia page, that the spectrum model should not be understood as a continuum running from mild to severe. So back in the day, again, those of you who have been with the mental health system long enough, remember that we used to look at, it used to be called mental retardation, right? When we looked at that diagnosis, and we would look at mild, moderate, severe, right? And so that was the spectrum that they used that terminology in. Now, when we think about autism as a spectrum, the spectrum isn't about severity. It's just about the broad differences that can occur between people. That every individual is unique and can have an infinite combination of different symptoms, but still fall under that umbrella. So again, it isn't like, it isn't about severity per se, but that autism can be different in different people, and usually is. There are sort of the classic stereotypical images that people have. Like sometimes people will think of Rain Man, that movie back from the 80s. It's a great movie with Dustin Hoffman and Tom Cruise, and just really, really well done. But not everybody with autism looks like that, right? There was a great TV show called Boston Legal. I don't know if any of you ever watched that. It was one of my favorites, but there was a great character in there. He was a tax attorney, and he was diagnosed, I believe at the time we were not in DSM-5 yet, and I believe he was diagnosed with Asperger's. But he had a very different presentation, right, from Dustin Hoffman's character, but they would both be considered under the same thing. So it can be so different that they don't always look like they should be in the same group. So that's just, again, it depends on where you fell in that continuum, most likely, or where your family member fell in that continuum as to whether or not you perceive that to be a good thing or not. So some things you might notice about folks with ASD. This is by no means all inclusive, but a lot of times folks will prefer their own company. They don't always attend to other people around them very well, or seem to care a whole lot about what's going on with these other people. They may have very rigid behavior patterns and expectations. So routine may be extremely important. And if the routine gets broken, it can be extremely disruptive. Strong resistance to change, which has a lot to do with the routine part, right? So like if we're expecting to do X, Y, and Z, and A, B, and C gets thrown in there, it can throw off everything. These folks usually have a lot of difficulty understanding sarcasm or abstract thinking. So this is, again, not a measure of intellectual ability, right? Like ability to, like IQ. This is really about the fact that language is a construct, and it means something because we say it means something. The tone of my voice means something because culturally we've assigned that. So someone who is not autistic may hear a dry tone of voice, right? If I say something like, well, I didn't pick up the phone that day when they called me, right? Someone with autism may be very literal with that and not understand my joke that I made, right? It can be really frustrating because for both non-autistic individuals and autistic individuals to try to communicate across that barrier, that gulf between ASD and not ASD, because what you think something means is probably not what it means to that other person. And so that can be super frustrating, and it can cause a lot of emotional distress for both parties. Reduced eye contact is kind of a stereotypical thing that we think of is folks with autism may not meet your gaze. Again, not always the case, but can happen. There's limited mirroring or reflecting back of emotional expression. This has happened to me, and this is probably where I encountered my first patient with autism. When I was I used to work at Daymark in Albemarle in Stanley County, and I had a young man who I saw for medication management, and he, I'm always trying to be funny, right? So I'm trying to get a reaction out of people. I'm trying to make them feel comfortable, and it was as if I was speaking into a soundproof room. Nothing was landing. I felt like the worst comedian in the world. Like there was nothing, I was getting nothing back. And I thought it was very disconcerting. Like I felt like I was really speaking a different language. And I think that I had that realization, and I thought, that's what this looks like. I've encountered it several times, and different degrees of intensity, right? Remember, not the severity thing, but, where I walked into a patient's room and it wasn't rudeness, right? But it was the reflection back wasn't there. And that's very common. And it can make interacting with non-ASD people very difficult because it can be off-putting, right? They can be like, well, that person obviously doesn't like me because I'm not getting anything out of them, when that's not what that means. But it can impact their ability to interact with people. Difficulty with symbolic meaning, right? So like I said, words are just things that mean something because we say they do, or somebody said they did back whenever words were invented, right? Whenever somebody put a bunch of letters together and said dog means this, right? Or, hamburger means this. It means something because we say it does, not because it has an inherent meaning. It's because we say it has a meaning. Symbols of things that aren't just words. So facial reactions, hand gestures, body stance, even things like tone, which can be considered a symbol, can be completely either missed or misinterpreted. Folks with ASD sometimes have difficulty with empathy. And again, that can be off-putting if you don't know what that means. It doesn't mean they don't care about you, but it means autism is really about being inwardly focused. It's turned inward, right? So their world is mostly in their head. And so anything outside of their head tends to be kind of either a distraction or kind of just doesn't make a whole lot of sense to them. So, and what that ends up doing, again, also kind of puts a barrier between somebody with ASD and without it. It can be hard, we think about what is empathy, and I've tried to explain this, right, to someone with autism. And the thing that's hard is it's one of those things that you go, I know what it is, but how do I say this? And empathy is really about putting yourself in someone else's shoes, right? Imagining what it would be like to be in that person, right? Or in that situation. That ability to conceptualize something that is not happening is really, really hard, if not impossible, for a lot of folks with ASD. To imagine putting yourself in another person's experience is just, it's like being on another planet, basically. And then finally, and again, like I said, not all inclusive, but mimicking social interactions, but not really understanding them. I had a patient one time who I think in retrospect now, I don't believe she was diagnosed with autism. It was when I first came to work for Wake Forest. And she had a phrase called, I go through life dollhouse living. And I asked her what that meant. And she said, it's like I move the pieces around, but I don't really know what they mean.
Schedule free mobile
Um,
service.
Oh, I think somebody might be unmuted. Just want to give, let's see here.
Yeah. Did someone
There we
have?
go. I think we're good. We're good. And I think that's just such an apt phrase, dollhouse living, that folks with ASD can be really good observers of behavior. And they can figure out, like, in this situation, this is what I'm supposed to say. But they might not really understand why they're saying it. And again, without that really inherent or cultural awareness of why you're saying what you're saying, they can just feel super lost in conversations or in social situations. So I don't know if any of you have heard of, and I will be the first to admit that I did not know who this person was before I met Rebecca and Margaret, but there is a very famous autistic person named Temple Grandin, and she described having autism as it's like being an anthropologist on Mars. And that's about the best way I can think of to explain it, which is if you were plunked down into a completely foreign culture, so foreign it's like another planet, and you're trying to figure out how to navigate it. And that is a lot like what these folks go through. And it's something that we take for granted, that we know what an eye roll means, or we know what a long pause before something means, or we know what that inflection means, right? But we really take for granted that everyone understands that, and folks with ASD really often don't. And so they're left kind of faking it, which is often called masking, right? They put on a mask to look like everybody else. And what ends up happening is that they then lose part of who they are, and they end up trying to blend in, but never really getting to be their authentic self. Which is why it's really cool that autism is getting so much more awareness now, and more acceptance, because it's really sad to think about how people have to just not be who they are, which happens a lot in mental illness anyway, right? Like, let's pretend that I'm normal, whatever that is. Let's pretend that I'm like everybody else, and I respond the way everybody else does, and I because I don't want to stand out, I don't want to be different. And the reality is that I think if we all realized how different we actually are from each other, we would have no concept of what normal was, because we are so vastly different. But it's so difficult to imagine just having to be somebody else, and then not even knowing who you are when you're pretending to be this other person. So that's kind of autism in a nutshell, basically. I did want to say that there are some things you might not know about autism. Not everyone with autism spectrum disorder is intellectually delayed. Not everyone has intellectual disabilities, or what we used to call MR, right? Back in the day, the developmental disabilities. Not everyone has that. Not everyone has a sub-average or even average IQ. In fact, many ASD folks are extremely bright and even fall in the gifted category. There's a wide range of verbal abilities demonstrated by folks with ASD. They don't all have issues with being verbal, hyperverbal, nonverbal. There's a whole range, right? There's some autistic folks who never really speak. And then there are some that never stop talking. And so it goes all the things in between. But again, like if you look at someone like Dustin Hoffman in Rain Man, if you haven't seen that movie, I highly recommend. But don't come away from that thinking that's what everybody with autism looks like. He's got very repetitive speech patterns, very kind of mimicky sort of speech patterns, and that's just one person, right? But when we make movies about people, we kind of have to have the stereotype or nobody knows what you're talking about. It is not caused by vaccines. If I can please just put that out into the universe, please be an ambassador for truth. When anybody asks you about this, it is not vaccines that cause autism. In fact, we don't actually know what causes autism. And I think the best evidence that it isn't vaccines is that when I was growing up, like everybody had vaccines. Like nobody argued about it, right? You just like stuck your arm out, you just stood in line, or you went, I mean, they were giving them at school, I remember. Like, you get vaccines in the lunchroom or whatever, which God forbid that happen now. But it's one of those things where we would all have autism, okay, if vaccines cause that, because my generation, we all got vaccinated. And that's just very briefly, the data that guy, that scientist, I don't even want to call him a scientist, put out there was all falsified. The guy that I won't put his name out there, but there was a man that promoted this theory because he believed it, and his research actually was falsified. So he had probably single-handedly impacted how many people got vaccinated after that, to be honest with you. So, but don't worry, it is not going to cause autism. It's not what it is. Even the ones that have the weird preservatives in it, okay, that's not what it's about. So it's really important to know that. Many people, both laypersons and professionals alike, so including myself, don't consider ASD a disorder or an illness, right? They consider it a divergence from typical development. So almost like an alternative way of looking at the world, an alternative experience of the world. I think that this is also fairly hotly debated, but you've probably heard the term neurodivergent or neurotypical. And I like that. That's, again, my opinion, right? I think that it's important to recognize that normal is just, it's a falsity. It doesn't exist. And there's sort of more typical, like more numbers of people maybe that have the typical development, but it's by no means just the only kind there is. So I think it's important to recognize that, because that also will allow people with ASD to begin to accept that they aren't broken, right? So that they don't need to be fixed, that they can just be who they are and experience the world in the way they experience it. And I think something that I've learned over the years is that words that we use are very important and they carry a lot of power. So, and finally, it is a condition arising from neurodevelopment. So our brains are developing all the way into our 20s. We don't fully finish brain development until probably 22 or 23. And so the whole 18-year-old thing is just a myth. Although ask any 18-year-old and they already think they're grown, but they're not. It's not a disorder or a divergent development that happens later in life, right? You might get diagnosed later in life, but it's not just suddenly magically appearing out there, right? It's been there, but a lot of people can compensate really well. And at some point later in life, when maybe stressors get too high, or maybe a trauma happens or something happens in their life that kind of derails them a little bit, then they can't compensate anymore. And then the symptoms or the experience kind of comes out, and the person begins to realize, like, oh, wow, all of these things that I'm experiencing differently that I've been trying to fake my way through, there's a reason for it. And I think that that's a really good thing that the autism awareness movement is creating, is the ability for people to kind of think, I wonder if I fit this pattern, right? Maybe I'm not like just weird and messed up. So again, it's about busting stigma. It's about creating dialogue and being okay with who we are in all of our versions. But nobody like magically gets autism at 40. All right. You either have it or you don't. And it's been there the whole time. You just might have camouflaged it well. So again, this just kind of, these are sort of some little bits and pieces here. ASD is considered as a diagnosis. We start to think about it when a person is beginning to have regular difficulties in social interaction or communication, right? It starts becoming noticeable that they're having difficulty interacting with people, maintaining friendships, staying out of conflicts. They often, like I said, have restricted or repetitive behaviors, which is often called stimming or stimulating. Self-stimming is a word you might hear. And for kind of the classic stereotyped autism picture, like Rain Man, right? Sometimes it's very much like we have to line everything up a certain way, and we have to, we have to hit the drum when we're upset, or we have to, there's something that kind of pushes the right buttons in their heads to either soothe them or make them feel better. And then resistance to change or restricted interest, like I said, like very rigid, routine-based activity that can be hard for them to change, or when they do change, it can all just blow up. Communication between autistic folks and non-autistic or neurotypical and neurodivergent folks can be super hard, because again, like I said, what means something to a non-autistic person may not mean the same thing to the autistic person. And so you're saying the same word doesn't mean the same thing, which again, if you don't have this disorder, can sound kind of weird and maybe like I'm making it up. But I can promise you that it really is. If you start asking the right questions of folks with ASD, you'll learn that they really, like, we take things for granted in our communication, and they really can't. They really, really can't. And then finally, ASD individuals may become very easily overwhelmed if too much information is coming into them. So whether it's noise or heat or smells or sounds or being asked to make too many choices or all of the above, it can lead to what has been termed meltdowns. And this is different from a temper tantrum, okay? An autistic meltdown is really considered more just like brain overload, basically. And it is something that is kind of like a snowball rolling downhill, where it's just going to stop when it stops, right? It can be just really hard. You can't really talk your way through it. You can't really explain your way through it. It just kind of has to decompress on its own. And really, it's not really about words that help someone decompress. It's really just about presence more than anything else. So some co-occurring disorders, and this again is certainly not an all-inclusive list, but it is very common to have co-occurring disorders with ASD. I'm reminded of the fact that in a psychiatric clinic, it's much more common to see a patient with maybe 5 diagnoses than it is to see them with just one. This is the case with ASD as well. It's not, if anything, it's probably riskier, not riskier, but it probably leads to more co-occurring disorders than if you didn't have ASD. So it's not protective against it. It's not like you just get this fun thing you have to deal with and you don't get anything else. You get to have other stuff too, which is super unfun for these folks, because not only are you trying to navigate Mars, you're also trying to navigate Mars while being anxious, depressed, manic, psychotic, whatever. I sort of put these up as the most common. ADHD is very, very common with ASD. It is extremely common, as high as 80%. I would argue that it just depends on the population you're assessing. I think ADHD in adults is remarkably poorly diagnosed, and I think that a lot more people have it than were ever diagnosed as children. And so I bet this number is actually probably a lot higher. Up to 84% of patients may have anxiety disorders, up to 58%. And again, I would argue probably higher than 58% of ASD folks may have a depression diagnosis. Up to 27% may have a bipolar diagnosis. So not quite as common, but not a nothing number. Intellectual delay, not even 50%. So this was my point, right? Like, not everyone with ASD is going to have an intellectual delay. And that's really, really important, because I think people hear that and think like intellectual difficulties. Epilepsy is actually the most common medical disorder that's associated with ASD, up to 39%. Up to 75% of folks may have learning disabilities. 88%, so this is the highest one, 88% of autistic folks will have sensory processing disorders, which again, when I talk about like sensory overload and they get like kind of brain fried, that's why those things can happen, right? It's just too much input at one time, which by the way is also a problem for ADHD. So it can all kind of like boom, 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 and all just kind of compiles itself together. Schizophrenia is fairly uncommon with ASD, but not unheard of. And OCD is very common, which you might expect given the rigidity and the rule-based behavior and the lining things up and all that stuff. Like all of those things, they kind of overlap with each other. So this fun little graphic here, right? Like all of these things, they can all go together. And I've certainly seen people, you know, I kind of joke to myself, like they have all the Ds, right? We have MDD and ADD and GAD and PTSD and all the Ds. And it can happen. I think the thing that's really difficult with ASD is that it just adds a whole other layer of complexity, because folks have a hard enough time. Let's just say all you got's bipolar disorder, right? It's hard enough to try to explain what that's like if you have it. Or let's say you have schizophrenia, right? It's hard enough trying to explain your experience. And then if you layer on top of that, I'm on Mars at the same time, it's just super, super frustrating. And there could be huge barriers to care because of that, because just getting a diagnosis can be super hard. Additionally, insomnia is pretty high. There's really no need to put a percentage on that. I mean, probably at one time or another, most people with ASD will have insomnia. Their sleep architecture gets kind of wonky. And interestingly, schizoid personality disorder, which is something that you guys may never encounter. It's a fairly rare personality type, but actually there's some data that shows that kind of running along the same rails for some folks with ASD. So I promise we're almost done, and then I'm going to be quiet and let you guys talk. Medication considerations. So it's important to remember that medications affect different people differently. And that sounds like a common sense kind of thing to say, but you know, in psychiatry, that's very true. You know, somebody responds great to Prozac over here, and then somebody over here has a terrible response to it. It's just, you can't really predict it. And that's where kind of experience comes in, right? Like, if I've seen this kind of person with this collection of symptoms do well on this medicine, this is probably what I'm going to try. This is especially true in folks with ASD or any neurodevelopmental disorder. So here at Wake, in our residency program, our residency clinic, we have a neurobehavioral clinic, which includes lots of folks with autism, with traumatic brain injury, with Parkinson's, which is a lot of things that affect brain function differently than just your garden variety anxiety, depression, bipolar, right? So these are folks that have developmental differences. And one thing that, you know, I kind of preach to the residents is all bets are off with these medicines. So if I think I'm going to give you this medicine and you're going to react like this because this neurotypical person over here did, I can't promise that's going to happen. In fact, I can almost guarantee you something different's going to happen. So it's very much a start low and go slow kind of thing. And, you know, being super cautious one at a time kind of changes, right? Because sometimes there's a really fragile balance that we're trying to maintain. Only Risperdal and Abilify medications, which you might be familiar with, have been FDA approved for behavioral symptoms associated with ASD. However, it's really, again, important to note that we're not curing anything, right, with this. We're trying to help manage and improve quality of life, but we're not, I don't have an antibiotic, right, for this. I don't have something that I can eliminate the illness by giving you a medicine. And that's super frustrating too, because it'd be really nice if that was the case. And I tell a lot of patients, you know, I would be so set if I had that medicine, you would have no idea. I would be like peddling something somewhere else. But there is no pill like that. But what the medicines can do is that they can help improve quality of life, right? For both peer, patient, client, and family. I would avoid seeking natural, herbal, YouTube video remedies unless approved by your doctor. It's always entertains me because a lot of people say, I want to use something natural. And the truth is, like, a lot of these alternative remedies are just as chemically based as any pharmaceutical agent I could give you. And we know a lot less about them, and they're a lot less studied. So I understand, like, just getting desperate and wanting to make something work, right? You use something, anything to make the situation better. But I can guarantee, like, throwing a wild card, like some kind of random, you know, infomercial drug in there is really just going to make everything worse. So I don't know a doctor out there that would tell you that we have, you know, that what we have is going to fix everything. But I can tell you that that stuff isn't going to either. And so we don't pretend to know everything. We don't pretend like we know everything. If you ever encounter a doctor like that, you should probably leave. Just, that's definitely my opinion. If you have somebody that thinks they know everything, you should just be like, that's great, I'm glad you do. And then go to somebody that's willing to tell you the truth, which is we don't. But it's really important to know that, you know, in this field, you know, the goal is to try to make things better. And the goal is not to withhold the perfect treatment. It's to find the perfect treatment if we can. But I can promise you it's not on QVC or whatever. It's just not. So I'm going to just leave you with this cute little picture, which I really liked. All of our patients are unique, but you need to figure out how you can fit into their puzzle. Because the truth of the matter is, like, our world, our neurotypical world is set up the way it is because there's more neurotypical people, not because it's the only way. And so it's imperative that people who don't have ASD, we have to realize that ours is not the only way of looking at the world. And we have to also make the effort to sort of be that anthropologist on Mars, right? To try to understand and help folks fit in to our world as well, because we don't have the only right way of doing things. So that being said, I'm going to shut up now because I was really, really chatty there. And I hope that that was somewhat informative and interesting for you. And I would love to, if there's no specific questions, we can just chat about experiences. And yeah, please open up and let me have it.
Okay, y'all, you can either indicate you have a question for Dr. Green by typing it into the chat, and I'll read it out to her if I see one. Or if you want to use that reactions button and, raise your hand, like it just showed up with me, then I can call on you.
Sounds
Okay,
good.
Julie has her hand up. So Julie, you want to ask a question?
Yes, thank you, Louise. Dr. Green, I think I understand the difference in what you were saying about some of the, quote, natural remedies. But how about the influence of diet and specific testing that shows that some foods really are not good for a person and should be avoided for their optimal health? Have you seen many cases of that in autism and know that diet is really helpful to them?
I'll be honest with you, I have not specifically looked into that. I would say that my patient population is fairly limited in terms of how many folks I have with autism. But I will speak to just saying that, yes, I mean, we know in many behavioral disorders, ADHD being a primary example of this, and I think autism probably falls in kind of the same kind of umbrella with that, is, we know that there are some foods that tend to aggravate behavioral conditions. There's been information about dyes and sugars and all kinds of things. And certainly I never tell a patient, if you have found that your diet, like what you eat or don't eat, dramatically affects how you feel and behave, I will support that 100%. I think I'm speaking more towards like, I mean, I've had patients, a good example, I can't think of the name of the drug right, or the name of the supplement, but I'm always having patients with like early dementia symptoms trying to buy these cognitive enhancers on TV, and like, who knows what the heck is even in them. And, they're asking me my opinion, and I'm like, I got nothing. I mean, I can tell you that, like, it's probably $85 for a bottle of that. And if you think it's going to help, I mean, I don't know, it might not hurt. I have no idea. And I think that's the thing. But diet, there's a huge body of literature out there. And so I have to plead some ignorance on this because I have not done a lot of investigation into it. But yeah, like I definitely think, some kids are very sensitive to caffeine. Some kids are very sensitive to sugar. There's some indication that gluten for some people can cause significant behavioral dysregulation. And so I would say this: if you, as a consumer or as a family member of someone, and you're looking for ways to optimize your loved ones or your own health, your own mental health with diet, I would definitely, do some digging into that, but talk to your doctor before you invest in like a really strict diet of something, or before you go out and buy like a whole bunch of supplements of something that sounds innocent. Just to make sure, I've this is a little far afield, but for instance, I think about like the keto diet, right? And I remember looking at that and thinking, that just doesn't look like it'd be very good for you. I'm not a dietitian, so I can't really speak to that, but I think anything done to excess can be dangerous. So it's really important just to talk with your doctor and say, I read that this, that trying to eat anti-inflammatory foods, right? I have a patient with rheumatoid arthritis who is following an anti-inflammatory diet with a lot of foods that are, have been demonstrated to reduce inflammation. And if she swears by it, and it's a healthy diet, it helps her. I have no problem with that. If she was only going to eat like grapefruit for the next 6 weeks, I'd probably have a problem with that. So I think that it's just important to kind of get your team's input. But I would much rather people be focused on nutrition and eating appropriately than I would going out and buying $85 of worth of some pill you don't even know what's in it. So
Good. Thank you so much.
Do we have any other questions? It seemed to me that, Dr. Green, that you were saying there, like my family member has bipolar and is on various medications for his bipolar that help. But there's not a medication specifically for autism. It's more to handle the depression that might go along with it or the anxiety that might go along with it.
Yeah. So the only two medicines that I think have been specifically studied in, and when we talk about behaviors, I think it's sort of like self-harming behaviors. Sometimes we'll have folks that will pick their skin to the point where they're bleeding, head banging, things like that. When you have really intense self-harming behaviors, or aggression behaviors, meltdowns that tend to be really destructive or dangerous to the person or their loved ones. The only two medicines that have been really studied enough, I won't say the only ones have been studied, but the only ones that have gotten like the FDA stamp of approval have been Risperdal and Abilify. And other than that, that's not to say that we don't use other things. And again, psychiatry, we think outside the box because our box is pretty small. We don't have FDA approval for everything, right? We have to go off label sometimes, and we have to try different things because the FDA hasn't tried everything yet. Things like Depakote for bipolar disorder, for example, that was an anticonvulsant. It is an anticonvulsant. We use it for seizures, and people just sort of happen to come upon the fact that it really helped with manic episodes, right? So a lot of things we found out by doing things kind of off the cuff. So that doesn't mean like someone with ASD, we wouldn't use other things besides Risperdal and Abilify, but those are the only two, to be honest with you, that have ever really been stamped as like approved.
Helpful.
Yep.
I know my family member who has bipolar, talked early on about how he had to mask his true self. I found it interesting that seems to be part of autism, which is a diagnosis he's never had.
Yeah, and I think what's interesting is that I think masking happens in a lot of mental illness, honestly, because there's just that stigma that's still there, and we really work super, super hard. I feel like it's a battle we fight every day, and I know that you do in NAMI as well. That's one reason I love NAMI so much, is that there's a real attention to stigma. And the truth is that when someone is given a diagnosis, whatever the diagnosis in mental health, whether it's ASD or bipolar disorder or whatever, there's real societal pressure to be normal and to act normally, whatever that means, right? Like I said, like there really isn't anything like that, but society's kind of got us set up. It's just a very simple example is, look at magazine covers, right? And these beautiful women and flawless skin and all of that, right? So what do? We go spend like bazillions of dollars on creams and junk and everything. And societal expectations don't just stop with appearance. It goes into how you behave. It goes into how you interact with people. And, you know, heaven forbid we're not like everybody else, which always makes me laugh when a patient says to me, well, everybody else has it together. And I'm like, well, first of all, you don't know everybody else. And second of all, no, they don't. The only people that have it together are the people you don't know well enough. Nobody has it together, really. But yeah, people with depression, you know, it's fake it till you make it. And a lot of people like really put so much energy, whether it's a major mental illness like bipolar disorder or even schizophrenia, when they have enough insight to do so, you know, of trying to be like everybody else. And it's just exhausting. It's exhausting. It's got to be exhausting.
Your analogy of being plopped down on Mars and trying to figure out how Martian society works, that's really compelling to me. That
Yeah.
all made me go, oh.
Yeah, and it's so interesting. And the more I read and learn about autism, I think about how challenging that is and how exhausting it's got to be, because we move through the world, you know, neurotypically, we move through the world without really thinking about it too much. And if you got to think about everything all the time, that's just, oh Lord, that's a lot. That's just a lot.
We've got a really, really long comment in chat.
Yeah, I was looking at it. Let's see here.
The question is down toward the bottom. What are your ideas on increasing accessibility to diagnoses, resources, recognizing an awareness, while keeping in mind that we do need some criteria to help in diagnosis?
Yep. Wow. Great question. And I wish I had the full answer. We do need to have criteria. We can't just say you got this and you got this, I just want you to have it, right? Like we have to have, that's why the DSM exists. So it's imperfect. It doesn't explain everything. Sometimes it over explains things. But we have to have some way to talk about it. And we have to have some way that people are kind of in a group together so that we can actually communicate about it and think about it in a way that will help the most people. I think that one of the things, and I'll credit one of our professors here, Naomi Leslie is a child psychiatrist here in our department. And she gave a really great talk on autism a long time ago when I first got here. And one of her points was, you don't, like, as a physician, like, as a psychiatrist, like we can make the diagnosis of autism. You can go through the battery of tests and you can go through, like, you know, there's Teach in Greensboro and at UNC in Chapel Hill, and they have numerous things. There's various clinics that will do all of the testing and the surveys and the diagnostic stuff and everything. And that is a way to do it, but there's just not enough of those people doing it. Like I mean, the wait time can be 6 to 8 months. I mean, to even get testing for someone that I think might have dementia could take as long as 6 months to even get on somebody's calendar. So what she said was, you don't have to do all of that. Like, it's a clinical diagnosis. And I know that that's true for something like ADHD. I feel very comfortable diagnosing ADHD because I know I don't need to have the little scales that you do for everybody. I know what the clinical criteria are because I studied it. I treat it all the time, right? And I think doctors, psychiatrists in particular, have gotten a little scared of, I'm going to label you with this because I don't have any proof, right? Those tests, those little scales and things, a person made those up too, right? Now they've been validated across research, but they didn't come from some mythological magic box, right? Like a person came up with that. And the truth is, like, there's nothing magical about that test, about any of those tests. And so I think what we really need to do is empower doctors, as Dr. Leslie told us, like, if you think this person has ASD, yes, it would be great to have the formal testing and the checkboxes and everything. But if you can go through the list, right, if you can go through those criteria as they stand and you can verify that clinically, then you can make that diagnosis. And that's how I've diagnosed autism in a number of people. And it's not invalid because I said so, because I'm not just making it up, right? I'm going through the criteria list. So I think one of the ways to improve access to diagnosis is to empower doctors, right? And that comes from our end, right? And teaching and training the doctors to say, you need to feel comfortable identifying this, because we don't have enough people out there to do the diagnosing. And the longer it takes to get diagnosed, the longer it takes to get help.
Proper treatment.
Yeah.
I think
Did I answer the question? I'm just making sure. I don't know who asked that, but I wanted to make sure I answered it.
The questioner said a one size fits all diagnosis can be harmful.
Mhm.
Yet having a diagnosis without any clearly identified criteria can be just as dangerous.
Mhm.
So what do you think would be needed to bring about a better resolution? And it sounds to me like it's training psychiatrists.
Yeah,
You
it's
answered
training.
the question. You definitely did. Thank you so much.
Good. Yeah, it's I think people get, I know people that won't treat ADHD unless the person's gone and gotten neuropsych testing. And I'm like, geez, Louise, do you know how long that takes? It's really some of it's time, some of, you maybe not have the time to go through the diagnostic credit, like there's a lot of stuff that gets in the way of people doing it. But I think a lot of it is just lack of confidence that I know what I'm looking at and that I can actually follow my instincts and follow the criteria, and like that means something, right? There's nothing in the DSM that says you have to go get this testing, right? It says, do you meet these symptoms? Do you meet these criteria? And if so, this is what your diagnosis is.
Yeah. Okay. Mary Miller has had a question for a long time. So Mary, you want to unmute?
Yes, thank you, Louise, and thank you, Dr. Green. This has really been very helpful in me getting a lot of information on this disorder, but but I find that it is really scary that there are only 2 medications that have been approved. I think you said Abilify and Risperdal. And also you said that diet maybe isn't that you know of really a helpful treatment. And you also said there's no cure. And it just seems to me that this is so scary, that where is the hope? How does this person live a comfortable life? I mean,
well,
I'm awestruck and that it's just awful.
Well, and I think observing it and talking to folks with it can be very, like, it gives you pause. It really does. But I will tell you that, what I didn't talk about, and I think you asked me to, and I don't think I got into it very much, right, is treatment, right? So there are different types of social skills therapy and cognitive therapy and, training to begin to help people learn how to, like we pick up, neurotypical folks pick up the reading between the lines part instinctively, right? We learn how to do that as a matter of developmental course and interpreting and learning how to do abstract thinking. And that's not something that may ever come super naturally to a person with ASD, but they can learn. A lot of folks can learn to do that in a way that will help them to feel more comfortable. But honestly, if I have painted a bleak picture, I don't mean to. I think it's that I want to really paint a picture of these aren't folks who are stupid. They're not unintelligent. They're
No.
not broken or defective, but it's a very different life experience for them. And I think that, you know, having supportive people around them, family members and groups like NAMI, you know, employment training, support, where folks can be around other people. And I know this is it's a huge absence in our community, right? We need places where people can meet other people like them. And realize that you don't live on an island when you have this disorder, but you can really feel like you do. But it's really, I think it's, and you can read this in a number of different books, right? It's kind of a superpower. It's a really interesting and amazing way to look at the world. And if you can foster a sense of curiosity in the person, right, to ask questions and to learn about other things that really come at it, as Temple Grandin said, like you're an anthropologist, right? Like you got to figure out what these crazy people on this planet are doing, right? And helping these folks feel comfortable doing that and not ashamed of it. Like society kind of tends to make you feel bad about yourself if you got to ask questions. And improving stigma and improving that sort of thing. You know, I think one thing that I experience with my folks with autism is a lot of times, like their emotions when they have them are very genuine and very like not childlike, again, in an intellectual way, but very raw and real. And that is to be able to experience that. I mean, it can be, if they're allowed to, it can be a full experience of life, right? Because they're wide open when they let themselves be, and I think that's amazing and something that we should encourage. But yeah, it is a spectrum, right? So there are some folks who are going to need help their entire life, and then there's folks that aren't, right? And so I don't want to. I do apologize if I presented a bleak picture. I really don't mean to. But I definitely, I want you to know that you know, different types of therapy, different types of support it can make all the difference in helping them kind of learn how to see the world. But the truth is we kind of have to do our part on the other side, right? And recognize that our way to see the world isn't the only way to see the world. That's a much bigger ask.
Yes.
That's a much bigger ask.
Okay, Dr. Green, in the chat, someone has, oops, I just lost it. Somebody has asked, who can diagnose ASD? Does it have to be a psychologist or psychiatrist, or can it be in an LPC or LCMA?
Honestly, it can be, if it's somebody, because even LPCs and LCSWs who study the DSM-4 or DSM-5, they use that manual to diagnose people all the time. So I think it is reasonable that they should be able to. I think somebody mentioned earlier, I think it might have been Kelly that mentioned, oh, what is it you said? There was something about like recognition of the diagnosis, right? And you'll have like I want to say facilities, what's the word I'm looking for? Organizations that like, okay, if you don't have this test, I can't say that you have autism, right? So there's also that. However, I think if you are accustomed to diagnosing any neurodevelopmental or neuropsychiatric disorder, whether it be autism or whether it be ADHD or depression or bipolar, I think it would fall in the category of you could diagnose it. Whether or not that's accepted by the powers that be as you actually have it is a different story, right? I think, again, if you're going to have Like if it's going to be like a basis for disability, right? They're probably going to want a psychologist or a psychiatrist to make the diagnosis. That doesn't mean, because to be honest with you, the testing that's done in these diagnostic centers like at Teach, those aren't MDs that are doing the diagnosing. Those are psychologists and counselors because they're administering the tests and the surveys and everything. So technically, like if I send somebody to one of these centers to get diagnosed, I'm not making the diagnosis. They are, and they're not MDs, which is really bizarre. But anyway, I think that they can. The short answer is they can make the diagnosis. Whether or not it's accepted by someone that needs that stamp of approval is another barrier that we kind of have to overcome.
Okay, and you've also got a question. How often is genetic testing used to confirm ASD? I know it's proving to be helpful in some cases of just mental illness.
Yeah, interesting.
Or helping with medication prescriptions.
Yeah, and sometimes I think that the promise of that is really far away. It's not like autism, because it's what we've realized, I think, is it's multifactorial, which means like genetics and biology have a part to play in it, but they haven't really identified a gene that we could say, like, for example, Parkinson's, there's a couple of genes that are very well known to be associated with it. And you can do a genetic test. And if you have this particular mutation, then you're probably going to develop Parkinson's, right? We don't have anything like that for autism. There's research being done to identify markers, but as of right now, that's very early. Like, I think being able to use that to confirm, it's still what I would consider a clinical diagnosis, which means you have to go through the interview, you have to go through the testing, the neurodiagnostic testing or the clinical interview to make the diagnosis, because we don't have, just like with, you know, depression and bipolar disorder, we don't have a blood test yet, right? We don't have a way to say, you know, here's this thing that tells you that you have this, which is why getting diagnosed with any major mental illness is really challenging.
Yeah.
Accurate diagnosis.
Right. Mary, your hand is up. Is that just left over from before?
It's left over. I'll remove it. Sorry.
I'm glad you can figure out how to do it. I was trying to get rid of mine early and it wasn't going. I think we might have another message.
So I did see something here about national resources that can be helpful. Yeah. I will put together like a list for you guys, and I can send it to you, Louise, and make it available. You can just make it available to whoever needs or would like to look at it.
Yeah.
Ask Jan for workplace. Okay, I don't know about that. I'm sure you can recommend. I don't know. What is Ask Jan for workplace resources?
Sounds like a website, maybe.
Yeah. Ask Jan.
Glenda, you have your hand up. I hate to do this, y'all, but I promised Dr. Green this wouldn't go on forever.
Oh, I love talking about this.
Okay.
I'm very chatty.
There's just two things. You mentioned a TV show, I believe it was a while ago, and when you were talking, and I don't know if you've seen The Good Doctor. That
I have. You know what? I should watch that. I should watch that, yes. But I have not. I've heard amazing things about it, though.
Yes, it's really good. I think it's completely off air now, but you could probably binge it or something. But I think the show is over, but it's really good. And then I heard Jenny McCarthy, is that her name, years ago, talking about the vaccines. And it actually sort of made sense to me in this regard only, that one size vaccine seems like it shouldn't fit all. If you have a skinny little girl and then this sort of a chunk of a guy, it doesn't seem like you would give them the same amount of the vaccines. But that was just the way my head was thinking. There's no scientific anything behind that, but just that part made sense to me.
Yeah. Yeah. And I think that a lot of, I think, first of all, you had the guy with the fake science, which was not helpful.
Right.
But, you know, you'll come across stories of people that like, well, my child was perfectly normal until they got their MMR vaccine, and then they started displaying symptoms, right? And, you know, again, as I've said, I think my biggest thing about it was, like, statistically speaking, I think it would be huge numbers of people that that demonstrated this, because it was one size fits all, right? Like, so we didn't just, and you know, kind of beyond the scope of what we're talking about today, it's, you know, there are a lot of medicines, for example, that your weight doesn't really matter, your size doesn't matter. Like, we use the same dose of Prozac for a 10-year-old as we might for a 40-year-old, right? So the dosing of the vaccine doesn't really make that much difference. But I will say that the world is full of examples where things seem to change for people after a certain medicine, after a certain exposure, after a certain illness. And, you know, I've learned that there are things in this world that we don't understand and that I can't explain. But I think, you know, just as sort of trying to be a good public health servant, wanted to say that, you know, when we have a disorder or a divergence like autism, we want there to be something we can do about it. We want there to be something we can do to avoid it. So if I don't give my child a vaccine or I don't feed them this food, then they'll be safe. And that is a misleading belief. And I think it's really, really important to say that, because the deaths that happen from preventable illnesses far outweigh the risk of autism. Even if there was an association, which there isn't, I would rather have my child be autistic than dead from measles encephalitis. Right. So I think it really, like, the waters got super muddy. And it made it hard for people to know what decision to make. And as parents, we're only trying to do the best thing for our kid. That's all we're trying to do. You know, we're not trying to do anything other than keep my kids safe. And, you know, I was super glad that I did not have an infant during the age of COVID, right? Like, my kids were old enough that I didn't have to worry about that. But, you know, I did not envy people that were dealing with that kind of thing. You know, we want what's best for our kids. And I think it is very human to say this thing is responsible, but it's also, we just kind of have to weigh it out, right? We have to weigh it out, and we have to decide where the greater risks are. But it's, you know, I don't think there's any easy answer. I certainly, you know, I respect everybody's ability to make their own decision for their kids, but I just want them to have information that they can rely on about that. And that's the most important thing for me. So, but yeah, Jenny McCarthy was a really big advocate for autism. Her son, I believe, has autism, and you know, she really put a face, a famous face, and I think that she was probably one of the first really good ambassadors. And I think we just have to keep fighting for equality, for awareness, for resources. You know, I call psychiatry the redheaded stepchild in any medical center, because we're at the bottom of the list, right? Like, I don't care. We just haven't gotten there yet. They're always going to put more money in.
Dealt with the brain, y'all would be the, you know, the most prestigious of all the medical field.
Well, of course, I think so. I think we're the most important. but yeah, so no, we don't have scalpels. But if we did, we'd get more money. But you know, not that what surgeons do isn't important, but there's a real imbalance in that. And so I think that's, you know, any advocacy and lobbying and jumping up and down and yelling that we can do for resources, for research, and for better, you know, training and diagnosing and all of that stuff, you know, is really important. And that's really the best way to help people. So
Louise, Dr. Green, I'd like to jump in because Mary Lee sent a message, but it said it was sent directly to me. And I don't think she intended that. It was an accident. But she said she is interested in peer support for people with mental illness, intellectual disability, and autism. And she would like some of the folks with these diagnoses who attend groups or at our mental health association in Stokes County to become peer supporters. What do you know about how they can get training and other training should they look at?
So there, and I'm not sure what's available in Stokes. I know in Forsyth County, there's the Mental Health Association, and the Mental Health Association has a lot of, they have courses basically like modules that you can do for certification and peer support, and RAP training, which is, I forget what it stands for, but it's WRAP, and I forget what it's basically.
Wellness recovery action planning.
Yeah, see, I should know that and I forget. But yes, thank you for saving me. And so I would actually, like, the guy that runs that, Andy Hagler, he is like a rock star. He's so amazing. He's run that place forever.
I think you're speaking to Andy's fan club here.
Oh, awesome. You know, honestly, he probably can point you in a direction for the individual counties, and he may be able to say, you can come here and take it. You don't have to be in your county. You know, you can come and take it here. I think that, you know, the decision to become a peer support counselor is really individual. I think it depends on where you are in your journey. And I think Annie would probably say that too, that it really depends on, you know, where you are and your own comfort level and your own acceptance of where you are now. But I think it's incredible. It's such a wonderful service to provide for people because, like I said, I'm sorry, what was that? Oh,
I'm
sorry,
not
I
sure
thought
it
so.
was intentional.
Okay, sorry.
The other thing that came up was, what is JAN? And Kelly put that response in the chat. It's actually the acronym for Job Accommodation Network that some people may find useful.
Cool.
Yeah.
So there is a link in the chat if you're interested in that response about JAN.
Cool, thank you. I am always looking for resources for my patients as well. So love to collaborate on getting things together so I can offer to other people. That's awesome.
Okay, and then it looks like Garnett has a question.
Yeah, thank you. So I just wanted to mention, I recently went to a genetic doctor for my oldest daughter, who is 27, and she does have a 15Q, which is indicative of ADHD, autism, kind of spectrum type diagnoses. And I asked her if she knew any resources for adults, and the answer was no, she did not. And she was with Wake. So Julia told me about this call. So I was hoping to hear more about the bipolar and the mental health and the tie into the autism, because like I've had experiences where she's been in the hospital and, you know, denied services because of the autism. So I've been looking for kind of the knowledge base of a professional that understands both.
So that she was denied admission?
She wasn't denied admission into the hospital or into a psychiatric, but she was denied like the partial hospitalization to kind of continue working on the behavior challenges she was having.
Yeah. And again, I think we're facing like lack of understanding in terms of the fact that there is a spectrum, right? And so there are going to be some folks that maybe might not be able to participate as well in something like an intensive outpatient program, and other people that will participate just fine. And I think what probably, I mean, I can't speak to this obviously, but
Right.
to your specific case, but there's like a one size fits all thing, right? Like, well, if you have autism, this is what it is, and you can't come here because you have this, right? Like, and I think that you know, again, and this is not the viewpoint of Atrium Health Wake Forest Baptist, but I think there's some lazy providers out there, and lazy programs who just don't want to take the time to do the individual assessment to see if it would be a good fit. You know, they're just kind of like, oh, you have this diagnosis, and so, you know, that's not going to work. You know, I think that it does make things very difficult in much the same way that like substance use disorders being co-occurring can get in the way of proper diagnosis and proper treatment for people. And, you know, I think it really, what it actually has to come down to is people being willing to do the individual work
Right.
and do the individual assessment. And, you know, because there may be very good reason, for example, why someone might not participate well in a particular program, but I don't think you're going to know that, right, until you do a more individualized look. And so, you know, I'm probably not super popular for saying this, but I've told people, I'm like, you have to be a loud, annoying advocate sometimes. You have to be, and please excuse my language, you have to be a pain in the ass sometimes. And you have to be loud, and you have to say, I'm not, you know, I don't accept that. Now, sometimes it doesn't work, right? Sometimes you get stonewalled, and that's just how, you know, those are the barriers that we're facing. And so I think I would definitely always encourage pushback. That doesn't mean you'll get through, but it
Right.
means don't just take it for what it is on the face, because you may encounter, you know, sometimes the longer you push, you find somebody, right? You find somebody that will work with you. But sometimes you don't. And so I don't ever want to say like, you're not working hard enough. That's not at all what I mean. It's just, I think sometimes people just get so frustrated. They just say, to hell with it. I don't want to fight this anymore. And that's, you know, that's just part of the problem. Right. But I
So
think,
with
yeah.
you, you said residents, so do
Mhm.
you intake patients and work with them and provide the therapy that they need?
So I'm not trained, me specifically, I'm not trained in like ABA therapy or the different kinds of therapies that we would use specifically for autism, you know, in terms of teaching social skills. And I think I told Louise this early on. I'm like, I have flown by the seat of my pants because I wasn't trained in this in residency. I mean, everything I've learned in working with patients and trying to find things for them that will help them. Predominantly because there ain't a whole lot out there. Now, I am going to put together, like I said, a kind of a sheet, because there are some programs out there. They are, one thing I've learned about North Carolina, unfortunately, that oddly was not true in South Carolina. I felt like the South Carolina mental health system was kind of well connected. It's super fragmented here. Like nobody knows where anything is. And it's so frustrating because, you know, I feel like, you know, people ask these very legitimate questions and I'm like, I don't have an answer for you. And that's just not acceptable. But when we decentralized or deinstitutionalized everything back in the 80s and 90s, you know, it was like 52 card pickup. They just threw everything in the air and said, well, I hope it all works out somehow. And so that's kind of where we are. And it's like manual labor to gather things together and say, here's this, you know, collection of help. But it doesn't just pop up. Like it doesn't exist in a coherent place right now. And that's really I mean, that's real. I have that experience just with mental health, not autism. Let's leave that out of it. Like just trying to find somebody to get a therapy connection is hard enough. And you would think as a psychiatrist, I'd have those people falling out of my pocket, and I don't. So it's really, we have our work cut out for us to get those resources pulled together.
I appreciate it.
And Andy Hagler at the Mental Health Association does a great job of that. He prepares various lists of agencies and their contact information and so forth. And if you call him and talk to him on the phone, he probably knows 3 or 4 more things.
He's one of those people, like he's about the closest thing to centralized information I can offer you.
Yes.
Right. But yeah, like I said, I mean, I've gone online and I'm just like, I've looked and I have found some things, but there's nothing centralized and there's no one place to go to get information. And it's really frustrating. So I think any efforts we can all make to pull stuff together, would be good for NAMI to have, just in case you get somebody calling and saying, what the heck do I do? Where do I go? Sometimes, but sadly, when you turn 18, sometimes there's just not a whole lot. And that's also a problem, but there are some things.
That was the dream and the accomplishment of one of our members, Glenda, wanted to pull together a list of all the free peer support groups for folks, because when you've been hospitalized and they send you home, they always say, one of the boxes they check for your follow-up is attend a support group, but they don't tell you where they are.
Right, where they are or how to find them. Yeah.
And so Glenda developed this brochure that we have that is a great resource for that particular part of the 52 pickup. That's a good example. You're good at analogies.
Thanks. Yeah, I love them. I think sometimes it's like the only way I speak is in analogies. So I'm like, if you need me to say it another way, let me know. But yeah, I that's how I understand things too. So maybe it's my own little bit of neurodivergence.
Okay, does anyone have anything else? I don't want to, we've got some really interesting stuff in the chat. So if you want to linger, I'll leave the meeting open if you want to linger and go back through and copy down some of the resources, like all that information about Ask Jan.
Mm-hmm.
That sounds very interesting.
That is, I'm very curious. I'm going to take a look at that. Oh yeah, there we go. I just clicked on the little picture.
Oh, is that what that?
Yeah, that's really cool. All right. Well, one more thing to put on my list.
Okay, well, hang on, one more message just popped up.
Sure.
Oh, the link's in the chat. Yeah.
Yeah.
For Ask Jan. The one I just put in, www.triadmentalhealth.org, that is the link to Andy at the Mental Health Association that we were talking about. Well,
Awesome.
Dr. Green, thank you so much for joining us tonight. I know all the folks who have been on this call have learned a lot and had some of their questions answered, and thank you very much.
Oh, it was my pleasure. I had a lot of fun, and hope we can all keep advocating and fighting the good fight out there.
Yes, yes.
All right.
And I'm going to declare the meeting over, but I'm going to leave. Let me see. Hang on. I want to stop the recording. There we go.